Welcome to the webinar about serving children with complex needs. This webinar is currently being recorded and is a duplicate to the webinar presented last week. The slides for this PowerPoint are not yet available. Apologies for that. Our goal was to have them available for attendees beforehand, but we unfortunately did not meet that goal. So the slides for the PowerPoint, the webinar recording, and a summary of the question and answer will be available after this webinar on the DSD archives. And we will also send an email out to all attendees, letting them know when those items have been posted. So throughout this webinar, please use the Q&A feature for questions, and we will be answering questions throughout the webinar as well as at the end. And the chat is not available during this webinar. So again, welcome. This webinar, Serving Children with Complex Needs, involves folks who have been working to address children with complex needs who are stuck or boarding in hospitals and other inappropriate placements. This webinar encompasses the most pressing information we have gathered thus far, and we would like you to think of this webinar as part one. So please look for communication about regional outreach that we are planning to begin sometime this fall. My name is Liz, and I work for the Minnesota Department of Human Services in the Child Safety and Permanency Division. And the vision for this webinar grew out of a few things. One was a myth that children are not eligible for waivers unless they have developmental disabilities. Another myth that agencies cannot have dual case management open at the same time, such as children's mental health and waiver. But it also grew out of several ideas, such as children with complex needs are crossing all silos of human and social services. And therefore, caseworkers have to know a little bit about a lot to ensure that children are getting the right services at the right time. The intention of this webinar is not to say that a child welfare worker needs to become a waiver worker or vice versa. Rather, it is for all workers to understand the scope of each other's service areas so workers can tap into the broad continuum of care to best serve the child. I did just see that a hand was raised. We unfortunately are not able to unmute participants and use the hand raising feature. So we would encourage you to use the Q&A feature to ask a question or to share any comments, and then those will be addressed throughout the webinar or directly through the Q&A feature. So these are our presenters today. They are from the Child Safety and Permanency Division, the Behavioral Health Division, and the Disability Services Division, all with the Minnesota Department of Human Services. As each presenter begins, they will introduce themselves further and then jump into their sections. So again, my name is Liz, and I am with the Child Safety and Permanency Division with the Minnesota Department of Human Services. This is our agenda for the day. We are going to first talk about what are complex needs. Then we're going to jump into some of the policy areas of child welfare, children's mental health targeted case management, waiver and waiver crisis respite services. Then lastly, we're going to talk about how to put it all together and resources. So again, the chat feature is not available. Please use the Q&A. And then following this webinar, the recording, the slides, and a summary of the Q&A will be available on the DSD archives with an email to all attendees when it's posted. And that email will go out to folks who attended last week and this week. This webinar, this is the target population of children with complex needs that we're talking about. These are children that are in foster care or out-of-home placements that have been or are in the process of being adopted or transfer of permanent legal and physical custody to a relative, that qualify for waiver and or children's mental health services and may require residential treatment services. And so as this webinar progresses, this is some of the information that we're going to be touching on and explaining more. So let's talk about what are complex needs. So this slide represents the areas that DHS receives information from to know that children with complex needs exist, and that due to the lack of access to services, these children experienced instability and crises. So the boxes, I'm going to read those starting on the left-hand side. So the first box is data from behavior intervention reporting forms, also known as BIRFs. Data from 245D licensed residential service terminations and suspensions. Hospitals, counties and tribes, providers, advocates, parents, legal guardians, and family, and the fragmented referral system that we're all working in. So the Disability Services Division has oversight of BIRFs, 245D service suspensions and terminations, and waiver case management, waiver case manager service planning. And through data from all of these sources that DSD has gathered over the many years, and DSD's interactions with these parts of the service systems, is how it was discovered that the system lacks and struggles with meeting the needs of specific populations of people. And so for this webinar, that specific population of people, we're focusing on children that are falling under the umbrella of children with complex needs. This next slide is covering some of the themes that we've seen for children with complex needs. So they're involved in multiple systems, such as child welfare and juvenile justice. They experience or have behavioral challenges, such as physical aggression or elopement. They have multiple service needs, for example, co-occurring disorders, mental health, or medical needs. And then they also experience personal factors, such as a trauma history, placement instability, or an adoption history. And this slide talks about, this is what we are seeing when children's complex needs are not being met. So for example, as I mentioned before, they're experiencing placement instability. Maybe a child is being sent to a hospital emergency department, or the police are being contacted, or they're being suspended from school. Again, much of this information came from the Disability Services Division through their BIRF reports, service suspensions and terminations, but it also has come through child safety and permanency through case consultations with counties and tribes. So before we move on, I do want to talk a little bit about why are we focusing on what we are in this webinar. So first, I'm going to explain a visual. Sometimes it feels like case managers are workers when serving children with complex needs. Walk into a warehouse and there's lots and lots of boxes, but none of the boxes are labeled. And caseworkers and managers have to open every box in order to figure out, is what in this box going to help the child that I'm serving? Serving children with complex needs is challenging because their needs require the intersection of multiple service areas that may fall outside of a worker's typical scope. And one theme that we've seen is that focusing first on the child's needs, then identifying if those needs can be fully served within your scope, workers can start to assemble a team to support the child, utilizing both their family or kin and professionals. And so the hope here is that we can begin to label these boxes so that not every box has to be opened in order to just figure out what's inside the box. And then this is our hypothesis. This is sort of what drives the work that we're doing for children with complex needs, is that when children have access to the right services at the right time, they are more likely to experience placement stability, preserve their culture, stay out of the hospital, maintain community-based services, experience fewer encounters with the police, child protection, juvenile justice, and other systems, and overall be safer, healthier, and have a higher quality of life. And I think that this is something that we all understand and we all know. It's nothing new, but it is something that we wanted to mention, as again, it sort of grounds the work that we're doing here. This visual, child's level of need, is going to be a recurring visual in our webinar, and it's going to help frame each presenter's information. So those of us involved in this work recognize how challenging it is to support people in the current context. For example, with staffing shortages and changes to services happening frequently. These levels of need are helpful in describing what to look or listen for to know that a person may need more or different services. So for example, things to ask caregivers about to better understand how challenging behaviors may be impacting the child and those that care for them. Next, I'm going to pass it to my coworker, Ashley.
Hey everyone, my name is Ashley Solsrud Beckman, and I am, as Liz mentioned, co-workers with her in Child Safety and Permanency Division. The area that we oversee is specifically child foster care policy, and I will have another colleague that will be presenting a little bit about permanency as well. So this section is meant to give you a very broad overview of what child welfare policy is and how it may come into play for children with complex needs. We're going to touch on some very specific points that we want everyone to know about, specifically about out-of-home placement requirements and permanency planning. And please keep an eye open for future webinars, including our regional webinars, where we will get more in depth on these topics and other topics. Next slide, please. We're talking about child welfare today in context of case management responsibilities when children are being served within the child welfare continuum and who may need out-of-home placement. However, child welfare includes a broad array of services, which include children who are at risk of foster care, children who have been or are in the process of being adopted, or they're being a TPLPC to a relative, children who are under the guardianship of the commissioner, and also prevention services, such as those offered under Family First Prevention Services Act, and of course, child protection. Next slide, please. So when we're looking at children with complex needs who may need residential treatment or out-of-home placement, it's important to know that when you are putting a child in many different types of residential facilities, that is considered to be an out-of-home placement. And so out-of-home placement requirements under child welfare policy are required. So some of these requirements include for the county or tribe to obtain placement authority, for there to be permanency planning with Typically, the goal of reunification, a relative or kinship search, an out-of-home placement plan, there's court oversight with a guardian ad litem, data reporting and SSIS, ICWA and MIFPA notices and active efforts, and then also monthly visits by the caseworker. So we're going to go a little bit further, like I said, into permanency in just a moment. And I'm also going to talk a little bit more about placement authority in a moment. I do want to mention with the out-of-home placement plan, many other case managers who are on this webinar today might be a children's mental health case manager or a waiver case manager, and you guys are also required to have case plans. When a child is in out-of-home placement, there's also something else required, an out-of-home placement plan, which is a separate plan from those plans required under children's mental health or disability waiver services. When a worker is developing an out-of-home placement plan, it is best practice for you to be coordinating those efforts with your other case management team involved. So you guys are all speaking the same language and you're all coordinating your efforts to help make sure that your services are supporting each other to support the child and their family. Next slide, please. So placement authority, what is placement authority? We've gotten this question multiple times. Placement authority is a legal document. It's a commissioner approved form, or it's a court order that gives the lead agency, county or tribe, care and control of the child or youth, and authority to make placement decisions for a child or youth. One common misconception that we've heard is that the waiver grants placement authority. And I think that that's a little bit of a misunderstanding on what placement authority actually is. So when a child is going into out-of-home placement, this either a court order or a legal document needs to be signed that establishes that placement authority. Now, the reason why this is needed, why this is required, is because it ensures child welfare protection and standards are followed while the children and youth are in out-of-home placements. That includes permanency and relative and kinship searches. And it doesn't matter what type of placement authority, voluntary placement authority or court-ordered CHIPS, these requirements apply regardless. So speaking of permanency, I'm now going to pass it over to my colleague, Alicia, to talk about permanency because this is an overarching goal in child welfare.
Thanks, Ashley. Like she mentioned, my name is Alicia Wolfman, and I am one of 3 permanency quality assurance team members in child safety and permanency. Like we mentioned, since permanency is a large focus of the work that we do in child welfare, especially once we have that placement authority, wanted to highlight different legal permanency goals that we often talk about. Reunification, custody of non-custodial parent, and then the specific area that mine does policy on is adoption and transfer of permanent legal and physical custody to a relative. Along with adoption and what I'll refer to as TPLPCs, there's also North Star Adoption Assistance and North Star Kinship Assistance that may go along and have children be eligible in families for as an additional benefit. When we are talking about adoption or transfers of permanent legal and physical custody, we have 2 types of placement agreements. We have an adoption placement agreement with adoptions and a kinship placement agreement for our TPLPCs. When we are serving these youth with high complex needs, it's important to talk about that these placement agreements can be signed based off intent and not the physical location of the child or the youth. So if we have identified a permanency home, maybe a youth was in one before they had to go to residential. If families are still committed and the intent is for them to accept that adoption or TPLPC, they can, and all other requirements are met, they can sign these placement agreements while these youth are getting additional services, might be out of the home with intent to come back. The other thing to keep in mind is that we are looking at in-state and out-of-state relatives must be considered, and we have different processes to assist with that. We have the Interstate Compact on Placement of Children when we've identified relatives out of state, not just for placement. And again, our statute really highlights now, not only are we identifying and notifying, but we're also engaging. And how do we do better engaging these families to either find legal or relational permanency? The other thing with out-of-state relatives is that our benefits do cross other states. So North Star Kinship Assistance and North Star Adoption Assistance can go to relatives out of state. Another thing to keep in mind is when we are working with children under the guardianship of the commissioner, if they are 10 and over currently and have been under the guardianship for 48 months or longer, as an agency, we can look at reestablishing parental rights. There was a recent statute change, so starting January 1, 2025, Hennepin, Ramsey, and other counties, if they want to opt in, the time frame has changed from 48 months to 24 months. So look for more information to come. The next slide, when we are talking, since a lot of the youth and children that we're working with are complex needs and have experienced either a TPLPC or adoption or in the process of that, is we have additional permanency supports that can assist both your agency or the families depending on where they are at in the process. We have the public-private permanency collaboration, which was previously PPAI, or the Public-Private Adoption Initiative, which is services available to children under the guardianship of the commissioner or tribal guardianship, can help with concurrent permanency planning, that family finding, free of charge to agencies. So keep the PPC agencies in mind. Along with, we have permanency support services, which is relatively new, and we have new grants and contracts to better support families for children and youth who have either been adopted or are in foster care or kinship care. All of these services can be found under the Permanency Services Resource Hub. There is special access for workers free of charge for additional supports and resources that you can access as a worker. But it's also a really great website for families where they can locate services based on their region. The other thing is that there's post-permanency reassessments available for children who have North Star Kinship Assistance or North Star Adoption Assistance. I think through some of the work I've seen since a lot of the children that we work with are either have been TPLPC or have been adoption, that these reassessments aren't being requested. So how can we get the information to the families about post-permanency reassessments or these supports earlier? And if the family comes in and asks for a post-permanency reassessment, it might be an easy way for you as an agency to re-engage with the family and identify if there's other needs or services that we could put in place sooner than later. With that, don't think there's any questions, but always please hesitate and ask, here to support. Wanting to bring back and recenter on this child's level of need, we'll now transition to Children's Mental Health Case Management Services. And before I turn it over to Di Marshall, who is our CMH representative, just going to take a look at this visual. These levels of needs are helpful in describing what you can listen to know if a person may need more or different services than they currently have. And with that, I will pass it to Di.
Hello and good afternoon. My name is Di Marshall. I'm the Behavioral Health, Children's Mental Health Targeted Case Management Consultant here at DHS. Was that a long enough title? So one of the things I just want to mention right away is that when I'm in a webinar or a meeting, if people are looking at other screens, it kind of drives me nuts thinking, are they distracted? So I'm not distracted. On my left, I'm going to be looking at some notes, and on my right, I might be getting notes that I need to be referencing with you. So please don't think I'm not listening to you, because I really am. Well, I'm not listening to you, but I'm paying attention to you. The reason that you can, next slide, please. The reason that we're involving children's mental health today is that children's mental health, when a child goes out of care, is part of the child welfare continuum, the child welfare service. So you noted just now the child welfare requirements, that also applies to children's mental health. So all the way through, we just kind of put that in your back pocket, saying, okay, they really are the same policy. The other thing, that reason that we're involved today, is you're seeing this grid that keeps getting brought up. A lot of that is children's mental health. And so we kind of look at it and go, okay, if kids in a hospital, could that child have children's mental health issues? Could they have a case manager? Hard to tell, but that's what we want to know. And that's when a case manager will come in and say, I will come and do some magic. I was being sarcastic about that. I will come and be part of the program and help the family. So we're going to discuss 3 things today. We're going to discuss the Children's Mental Health Targeted Case Manager's responsibility. We're going to talk about that crisis plan that a case manager is going to develop with the family. Keep that person-centered lens in there. And then we're going to talk about the movement either to or from a more or less restrictive environment. And also, and then I am going to get to this slide, believe it or not, to follow about the theme that's been discussed earlier, where we talked about myths. Pretty common misconception I hear is people saying, well, if they have a waiver worker, they don't have a children's mental health case manager. It can come in a couple different ways. You can have a case manager from waiver. You can have a case manager from waiver and children's mental health, or you can just have a children's mental health case manager. There is a way to double bill if you do dual case management. And then also, just so you know, I think there's kind of a misconception out there that the children's mental health case manager can also do a waiver. You need to have a waiver worker to do a waiver. So how's that for waiver? Too many times in a sentence. So the biggest thing I often talk about is let's communicate. And I do say that when people call in. DHS does not have a specific policy about what happens with that. So I really would like to see county departments talk to each other. So with that said, I think we're on slide 20. So what do case managers do? These are actually the 4 MA billable activities. When you're doing a TCM hit, you're doing one of these. And they have to be done once a month. If you're working with children's mental health, I'm kind of making a distinction in my head between adult mental health. You can do an ITV video once a month. You can meet with the child face-to-face once a month. And so during that time, these are one of the activities you'd need to do. 1 is conduct an assessment. 2, plan some goals and establish them with the family. That's the IFCSP, the assessments, functional assessment. And then 3, linking and referring to the services to meet that child's needs. Again, you'll have talked with the family this whole way along. I know when I was back in the field, it was easy to sit at my desk and do my own functional assessment and do my own plan based on what I had heard them say or what I read in the DA. That's why I'm saying their voice needs to be really involved, that parent, that child. And so where does the parent or child want to go get the service? We're looking from an equity lens. What's part of that person's community? If a child's from a tribe, are there services there? And then finally, the last billable service is to monitor and coordinate the services and monitor how those goals are going. You might have a service set up that isn't really part of the goals, isn't working, and maybe one of your goals is just not getting addressed at all. So during that time period between the FA and IFCSP construction, and then the next 180 days, you might say 3 months in, man, this isn't working. Goal A is not happening. And so at night might need to be adjusted, and you can make that decision with the family. So next slide, please. Okay, I just told you what the services are that get reimbursed, and this is how it's defined in statute. I won't read that to you, but you'll probably see in there well, I know you will, assessment, planning, linking, monitoring, coordinating. That's what MA will pay us for. And this is kind of one of our bottom lines that we always want to come back to this service. All right, next slide, please. So who can provide these services? That can be a tribe, and we have 11 tribes in the state of Minnesota. If a kid goes out of home into care, the 3 lead agencies on that would be Red Lake, White Earth, Leech Lake, and soon to be Mille Lacs. Went 5, but I meant 4. Case management agencies that contract with counties, and then the counties themselves. And then finally, those agencies that contract within an MCO. And then it can get kind of confusing, but when we talk about waiver, you'll often hear about the lead agencies. That's not really how we reference it with children's mental health, adult mental health. We'll be talking about these providers. Okay, next slide, please. Okay, so the other thing that we're going to get to, okay, first of all, we want to make sure that we know that if a child is going to get a service, it's voluntary. So they can say, I'd like this service, but they could also say, I don't want it. And more so, I should probably say the family too, but the way statute reads, it says child and family. And then these are the requirements that we need to meet in order for that you to get the service. It's all contained within the Children's Mental Health Act. And a child to be able to get case management has to have a severe emotional disturbance. That's one step up from an emotional disturbance. So let's go and see what's on the next slide. So there's 4 different ways, 4 different criteria that we need to meet. And I'm going to have you read them too, because I know I have a dear friend who says I hate it when people read slides to me. So I'm not going to read the slide to you, but you're going to notice the criteria as it relates to inpatient residential treatment. And that's in both of these. Next slide, please. And with the other option, so that you have to have one of these 4. The next one can be one of these. A person has psychosis, risk of harm, psychopathological symptoms. And you'll notice all the way through, by the way, it might say within the past year or may happening within the next year. Then let's go to the next slide. Okay, this one I like to hone in on. You know, I talked a little bit about dual case management a few minutes ago. A case that I have been getting, a question I've been getting for many years now has been, what about a youth who has ASD? Who should best serve them? And as I mentioned, we don't have a policy. What we talk about is encouraging the 2 areas within the county to talk to each other, 2 providers, and say, hey, waiver area, hey, children's mental health area. It'd be good for you to talk about what's this child's needs, what kind of services do they need, what do you see that maybe their level of functioning could benefit from. And then again, at that point, then it's like, well, should both areas cover? Maybe between your discussion, you're going to figure one area will. But children with ASD often fall under this criterion, and that would make them eligible for CMHTCM. Next slide, please. Now, who gets to have the service? By Minnesota statute, it is for a child under the age of 18. Can you go to the next slide for a second? I want to check something out. Or, see, I had to see where that was going. Or it can be a person over the age of 18, but under the age of 21. Right now, the billing on that's kind of hinky. So they can get the service and they need to indicate that in whatever mechanism you're using. SSIS, you'd indicate that it's the Children's Mental Health Service. The billing needs to go to adult mental health because of that statute I just showed you before. Okay, next slide, please. Crisis planning. You know, that's something we haven't talked about much before, but try to talk about it more now, especially if we talk about it with kids with complex needs. I look at it like it almost should be part of the IFCSP. When you first start meeting with people, how is it that you're going to develop a plan that can keep a child at the lower end of the continuum? And there's a couple different lenses that we should always come in with. One is the person-centered lens. What's important to the family, the child? Who's important to the child and the family? So if they're needing informal supports, lower end of the continuum, maybe I always use Uncle John as an example. Maybe Tommy does really well at Uncle John's house when he's really getting dysregulated. If he is, can we consider that when things are in crisis? That should be written on the plan. How about some mental health services that may not be meeting the criteria of actually going to see a counselor? Maybe they want to see their pastor. So those are some informal supports. More formal supports might be that you're going to set up some counseling, see a therapist, maybe some in-school programming. So the crisis plan should include all that. The crisis plan is basically to be saying, before this stuff happens, what are we going to do to get ready so that we don't have to get to the point where law enforcement gets called, mobile crisis gets called, and really that they go into the hospital. This is also part of an equity lens. Part of the equity lens is we want to keep people reinforced and support people in staying in their community, into their own values and cultural priorities. So I always kind of keep that in the back of my head is, how do kids do better? They do better when they're with their own beliefs and cultural values. And the same with using that person-centered lens. Sometimes that can't happen. And sometimes it does need to go to the next step. But a crisis plan does serve to have that function where it keeps a youth using those lesser methods, I guess, if you will, and what good social work practices anyway, which is the equity practices and the person-centered practices. Next slide, please. Okay, so here's the elements we want to consider when we look at the crisis plan. What's the mental health treatment? And this is what you're going to talk about with the family. What's the mental health treatment history? What's the current risk to others? During the pandemic, we saw that was a super hard time. It was also the time of a lot of racial unrest. So we saw kids, it was a perfect storm of stuff. Kids were home, parents were home. There might have been some domestic violence in the home. People were getting isolated. Kids weren't in the school. And then the racial unrest was really a lot of oppression. So we had to look at then, a lot of kids were kind of presenting more, I don't even want to say kind of, were presenting more at risk to themselves and to others. There might have been a situation where a kid was breaking into a wall because of the anger. That's why the ITV contacts you had was so important, because you needed to see that kid, but it also allowed you to see the child on a video, and the parents you'd be able to assess, how is he doing? How is she doing? How's the parents doing? Does it seem calmer? Are you seeing damage to the home? Then also a description of situations that have led to crisis in the past. So the example I just gave you. What factors make it worse or precipitate a crisis? Well, if mom and dad might be having some issues, that could be an issue, that's a situation that's precipitating a crisis. What's improved it? Again, like Uncle John might be a really calming influence. This can also serve to be a prevention plan. And then using, again, the informal supports. Get creative and encourage the parents to be creative. Help them to own that plan. And then behaviors that are related to the emergence of the crisis. We used to call it the ABC, the antecedent behavior and consequence. So this is the antecedent. All right, next slide, please. So what do we do then? We've said, okay, here is the current situation. Here's the history. Here's what we know what happens. Then what could happen if that's the consequence in a way, if you will. That's where we might have to look at going. They might need to go to acute care, crisis placement, community resource, and emotional support. That should all be written there so the parents have it. Sort of like when I used to do plans with families, you almost wish you could just give it to them and put it on the fridge, right? Well, this would be one of those documents that they could keep, the family could keep and say, okay, things are going rough. I've tried all of this. It's not working. And this is some resources I'm going to have to work on now. It does address some of those strategies that you need to do when a crisis, when God forbid that the child is at risk of suicide or self-injurious behavior. But key at the bottom, crisis planning does not include services to design the secure the safety of a child who is at risk of abuse or neglect or necessary emergency services. So always want to kind of tease that out a little bit. If they have those situations, sorry, I got distracted. Something came up. They may need to call 911 if it's child protection. Next slide, please. Next crisis, please. Okay, so now we've reached the tipping point. We've done what we can to say we've worked on a crisis plan. Here's what's going to happen if things kind of start not going well. But then now things definitely are not going well. The assigned case manager must be contacted if the child is hospitalized. And pardon me, I always say kid. Sorry about that. Sometimes it'll happen on a weekend. It might happen at the night. So most case managers are not on call. So that next day, the case manager must be called. So the family work with, please encourage them to make sure you're contacted. And because there are other providers from the tribes and the MCOs and the contract agencies, please ensure also all those MHTCM providers are contacted. And as I mentioned too, the person-centered lens, this decisions should be made with the child, with the family, or legal guardian, and the case manager. And to look at the lower end, the continuum, the least restrictive, rule that out if it's unworkable. And then continuing to really, really focus on that child's mental health. I like to think of it sort of a wraparound approach too, is that we put the child in the middle of the table and all of us go, what's best for Tommy? Because it can be tough when there's a lot of systems involved to get our egos aside. And if we keep saying the onus is on Tommy, things will be better. Next slide. And that goes back to the common theme. What's our emerging need? What's our significant need? And what's our urgent need? And that's just what we went through now. Next slide. Okie dokie. Is there any questions at all, Ashley?
No questions, Di.
Well, that's terrific. Good to see you all.
All right, good afternoon, everybody. I am Cassie Tulp. I'm a regional resource specialist, and I work within the Disability Services Division of the Department of Human Services. And I'm going to be doing just a very brief high-level overview of disability waiver eligibility and MnChoice's assessment process. Next slide, please. Minnesota's disability waiver programs provide home and community-based services, or HCBS services, to meet the needs of people with disabilities and older adults. Minnesota developed HCBS waivers to meet the needs of people who choose to receive services and supports in their home or community rather than in an institutional setting. For eligible people, these service options are available in addition to services covered by medical assistance, or MA. To be eligible for a disability waiver, a person must choose to live in the community and must meet all of the following criteria. They must be eligible for medical assistance based on a disability or other eligibility status, be certified disabled by Social Security or the State Medical Review Team, also known as SMRT, be assessed using MinChoices to need an institutional level of care, and have an assessed need for supports and services beyond those available through the MA state plan. Next slide, please. Next slide, please.
See, this is Liz. I have the disability certification for MA eligibility up. Is that where you need me to be?
Thanks, Liz. My computer
Yeah.
has a little delay, I think, so thank you.
Yes, I think I am too. Sorry about that.
To qualify for medical assistance, a person needs to be certified disabled or certified as blind. This certification must be from the Social Security Administration or the State Medical Review Team, as stated previously on the slide before this. The certification process is also called a disability determination. A person must be certified disabled in order to receive home and community-based services through the waiver. Next slide, please. So anyone may apply for a waiver, and a person may contact their lead agency at any time to request a MinChoices assessment. A person's lead agency is responsible to determine financial and program eligibility for a person who requests services and supports, as well as provide ongoing case management or care coordination for a person on a disability waiver, including support plan development. Next slide, please. For people accessing a disability waiver, the county where the person is located at the time of the assessment request is responsible to complete the assessment activities. In most situations, the person's county of residence completes the assessment activities. However, there are situations when the person may temporarily be located in another county. When the person is in a county other than their county of residence, the county where the person is located is responsible to complete the assessment activities. During the assessment and reassessment process, the assessor works with the person to determine eligibility for waiver programs and services. The assessment process also includes support planning. After the assessment, the case manager or care coordinator creates a support plan in partnership with the person and their legal representative when applicable. Next slide, please. The person who receives services is at the center of the support planning process. The certified assessor, case manager, or care coordinator will lead the process with the person. The case manager and certified assessor work together to share information and provide continuity of care throughout the assessment and support planning process. The case manager and the person develop a person-centered plan and identify the person's goals, needs, preferences of how the person will receive services and supports. Next slide, please. All right, so that was a very quick and very high-level overview of waiver eligibility and MinChoices. On this slide, you will find resources on how to find out more about waivers and waiver access. And I am going to hand things over to Amber to transition into talking about some of those waiver services and the scope of those impacting children at risk of or in foster care.
Thanks, Cassie. This is Amber Mackey. I work in the Disability Services Division on the Community Capacity and Positive Supports team. A lot of my work involves people experiencing crisis. I've done some work on our behavior intervention reporting forms, some technical assistance to counties, specifically waiver case managers, and kind of just everything crisis related. So Cassie teed us up really nicely to talk about a specific waiver service, and it's referred to as waiver crisis respite. So with the level of need spectrum here, waiver crisis respite is most appropriate for someone at a significant need or an urgent need. So let's jump back to, I think it's a green slide. Okay, this is good. So just for reference, this waiver crisis respite service is available on the BI, CAC, CADDY, and DD waivers specifically. Just want to make sure everybody was made aware of that. On this slide, there's the crisis respite definition, eligibility. This information comes directly from policy. The Community-Based Services Manual, CBSM, has a page specifically on waiver crisis respite, and that is considered the policy on this service. So this service is reactive. It's not proactive, it's a reactive service. It's meant to be initiated when a person's experiencing a crisis. It's really intended to be short-term and provide some relief to support the caregivers and others who might be living with a person who's putting themselves and others at risk, their health and safety at risk. This service is intended to help people identify and cope with immediate stressors, find additional resources, develop action plans, and really at the end of the day, avoid unnecessary institutional placement. So avoidance of any sort of situation where the person has to move to a non-community based setting. In addition, the idea behind this waiver service is to support a person to return to their baseline level of functioning as it was prior to the crisis. So what that means is this service isn't going to come in and fix anybody. It's not going to, make the person outstanding, above and beyond great. It's really just whatever that baseline level of functioning looks like for that person. And that could mean they're still throwing things or hitting or kicking or biting, but that's what their baseline looks like. The idea is to figure out how to safely manage those things in a community-based environment. With this service, it's intensive, so it includes specialized staffing. There's a focus on assessment to determine the factors that cause the crisis, and then develop a person-centered intervention plan based off the assessment that supports the person to avoid future crisis. So what can we learn from what happened that led the person to being in crisis, and how can we prevent it from happening again? Providers delivering this service also provide technical assistance to other community-based providers, and I'll talk more about that when we talk about out-of-home crisis respite. The providers also recommend positive support strategies that are working to support the person. And the other part of this is the development of a transition plan to promote continuity of care. And that's specific to out-of-home crisis respite, which I will get into further in just a minute. So eligibility, both 1 and 2 need to be present. The person needs, the caregivers and service providers are not able to provide behavioral medical interventions, and the service allows a person to avoid that institutional placement. This service is basically silent on age, which means adults and children can get this service. There's no age limits or stipulations. However, the provider who's licensed to deliver the service, they may place age limits on their service dependent on their qualifications. On the next slide, we'll talk about when to initiate the use of crisis respite. Again, reactive service, things are clearly not working out or going well. The police are being called. Person has probably been hospitalized 1 or more times. There's a pretty clear indication if things continue, the person's going to lose their current residence. With licensed settings, 245D residential services and supports, their services can be terminated or suspended, which means they will lose their residence. In addition, when a person is hospitalized, you might see the hospital staff are struggling to keep themselves and others that are in the hospital safe, and they'll resort to using medical restraint, mechanical restraint, and seclusion to try to manage the person's behavior. At this point, because the police have been called, there's very likely some charges and court dates that are now set up and happening. And for families specifically, they often at this point are reporting exhaustion. They're thinking they have to quit their jobs or drop hours at work. And they're really in fear of the health and safety of others living in the home, including sometimes their pets. Next slide. So this waiver service is really unique from a lot of the other waiver services in that it can be really flexible in how it's delivered. So 15-minute units, that means the service is really, it's mobilized. It goes to where the person is. It goes to the family home. If they're in an adult foster care or child foster care home, it goes there before their services are terminated. In a community setting, maybe they're having issues at work. So it goes to where the person's experiencing the difficulties to address it right then and there. Under daily, crisis respite can be provided in home daily, which means it's provided in the family home or the person's own home. These are not licensed settings. The family owned home or the person's own home. Out of home crisis respite. Now the person has had to move to get this out of home crisis respite service. And that does have to be delivered in a licensed setting. And that needs to either be adult foster care, child foster care, a community residential setting, or a Minnesota Department of Health licensed hotel. And we'll just go to the next slide and talk more about the hotel option. So the intention behind having this option was really, the idea was that the person might be having issues in their own home, the family home, in a licensed home where they're living, and everybody just needs a little bit of space and time. So let's go to a hotel for a week, reset, maybe get some additional services in, some training, person goes back home. It was never meant to be a place where a person transitioned from a hospital, from jail, in place of housing, because they have no other place to go. So just a caveat about that. Most of the metro counties require that their case managers and contracted case managers get approval from them, the county leadership, before using crisis respite in a hotel. So prior to using this service, if you're looking at it for anybody on your caseload, check with your supervisor and your leadership to make sure you do or do not have to get prior approval. This is extremely short term. It is 7 days. There is the option that if it has to go beyond the 7 days, you need to notify DHS. And every week thereafter that the person spends in the hotel receiving this service, you have to provide updates and request an extension. So that means if someone is using this service for 3 months, you have to email, spoiler alert, me 11 to 12 times. So I would be your primary contact. The process for doing that is also in the Community-Based Services Manual, the CBSM Crisis Respite Policy page. Okay, next slide. We'll get into some details about the different ways this can be delivered. So 15-minute. Again, the location, it's mobile. It goes to where the person is. There's no age limit and there's no time limit. For Crisis Respite Daily on the next slide, in-home daily, again, person doesn't have to move. So the service goes to them. There's no age limit. And I mentioned some providers, they may have some age limits, no time limit. For out-of-home daily on the next slide, again, that location has to be one of these licensed locations. And because of that, there now comes in an age limit. So child foster care, serve children. Adult foster care, serve adults. In addition to having an age limit, there's a capacity limit. These homes are typically 4 beds. So there's a maximum of 4 people that can be served in the homes too. There's a time limit. So for adult foster care, child foster care, or a CRS, it's 180 days. And then for the hotel, as I've already mentioned, it's 7 days. And I believe we were going to pause here and check and see if there were any questions at this point.
Hey, Amber. Yep, we for sure have one here. So let me pull that up. The question was, is there a comprehensive list of crisis respite locations and contact information?
Okay, that's a great question. Yes, and I have that. So there's some emails at the end of the PowerPoint. So email, it's going to be the positive supports at state.mn.us. Email that, they'll connect you to me, and I will send them to you. And how I got that list, DHS licensing lookup, you can look up who is licensed in what are called the waiver intervention services, which include positive support services, crisis respite, and specialist services. The drawback to that is that you have to, once you get a list of providers in your county, click on every single provider to open their page and go see which of the 3 they offer, because some only offer specialists, and you won't know unless you open that. So I've created lists where I've gone in and I've done that to try to save waiver case managers as much time and trouble as possible. So great question. Any other questions?
Yep, we have a couple more here. The next one is DHS educating the hospitals about the intent of this service. Hotel crisis respite has consistently been pushed by hospitals for those kids that are stuck in the hospital.
Yes, we are having conversations with the hospitals, and we're having conversations with some of the providers who go to the hospital and walk the halls and advertise this option. We are constantly sending the message to providers and hospitals. They need to contact the waiver case manager, contact the waiver case manager, contact the waiver case manager. You can't do this without contacting the waiver case manager. So yes. And anybody else out there, feel free to say that yourself. Contact me before you have the person move, because it's happened, unfortunately.
All right, we've got some more questions rolling in here. The next one is, who is paying for the hotel?
Okay, so the policy talks about the hotel, cost of the hotel, staff, and I believe food cannot be paid for with waiver dollars. So it is the provider who is paying for those things.
All right, and then the next one here, if an out-of-home crisis respite home is longer than 30 days, is it considered placement and need placement approval versus just coordinated respite? And that might entail our other friends here on the call.
Yes, Ashley, she's the expert.
Hi, yeah, thank you for the question. I will respond to that in the Q&A so that everybody will have access to the Child Safety and Permanency Division issued a policy bulletin that covers this topic in depth. And when a child is placed in a CRS, that would require placement authority. And when a child is placed in a hotel with crisis respite, if there's multiple stipulations that I won't go into here specifically, but it is covered in depth in our bulletin. And Liz and I will also be doing another webinar specifically on placement authority in the next month or 2 here. So you can keep your eyes open for communication about that as well. So I will link the bulletin to your question. And then if you have further questions about that policy, you can email our Child Safety and Permanency Foster Care Policy area And I'll put that email in the chat or in the Q&A also.
And I think it's also at the end of the slide deck. We've got everybody's email at the end of the slide deck. Okay, any other questions, Corey?
Nope, that was all.
All right, let's go on to the next slide. Okay, in the waiver crisis respite policy, it talks about providers need to have the experience, skills, and qualifications necessary to meet the person's individually assessed needs. Period. Okay, there's no examples. There's no further explanation. So how do you figure that out? I've come up with some examples that people are free to use when vetting a crisis respite provider. I actually had a case manager who went to the session last Wednesday reach out to me last week and shared with me some answers to these questions that she used to vet a provider. It was fantastic. So for specific experience, I mean, hands down, they need to know how to work with people with challenging behavior that's dangerous to the person and others. Some people who are utilizing this service are doing it because they've been denied for more restrictive services, like an institutional level of care, because the institution said they're too aggressive. But yet, this provider now needs to be able to support that. So it seems like a no-brainer, but I put it on there anyway. Let's double check. So any of the procedures described in 245D06, subdivisions 5 through 8, that covers things like mechanical restraint, levels programs, the use of positive reinforcement, punishment, and the development of positive support transition plans. These providers who are licensed in this service are required to have the skill and expertise to write a positive support transition plan, which also means they have skill and expertise in doing things like a functional behavior assessment. If you ask the provider, do you have an example of a redacted positive support transition plan I could look at, or what's your timeline for creating these plans? And it's deer in the headlight look, they don't even know what you're talking about. That's a huge red flag. That would be a big problem if they don't know what a positive support transition plan is. On the next slide, there's a few other examples for experience. Preparing written intervention strategies. Could ask for a redacted example of an intervention program that they wrote. Take a look at how they wrote that. Do they have all the pieces in there? Did it make sense? In addition, having a conversation about emergency use of manual restraint, especially if you know the person in the past has experienced the use of emergency use of manual restraint. It's probably likely they're going to experience it again. If the provider says, we don't do that, we're hands off, that could be a big problem for this specific person. So what does the provider do then when the person starts to punch them in the face? If they don't utilize a emergency use of manual restraint? What about if the person engages in such severe self-injury that they're causing major damage to themselves? How do they intervene without the use of emergency use of manual restraint? A lot of providers are confused about this. They think they can't use restraint. That is false. It can be utilized in an emergency where it's a clear threat to the person or others' health or safety, and that needs to be used to regain safety and keep the person safe. What you can't do is write the use of manual restraint into a behavior support plan to punish a person. You can't do that. So having that conversation with the provider is a really good idea, because hands down, chances are they're calling 911. And once that happens, the person might end up going to the hospital, and the provider then has a little bit of time to think on their hands, and they say, you know, we can't really help them. We can't meet their needs, so they can't come back here. I talked about functional behavior assessment. It is defined in the positive supports rules. Statute is provided there. How do they train others in program implementation? Do they keep track of how things are going, to make recommendations on changes to enhance programming. On the next slide, we'll talk about skills. So data collection and analysis. How is the provider collecting not just challenging behavior data? That's pretty common in a lot of provider environments, but what about the use of psychotropic medication and symptom management? How have they defined, anxiety for that specific person? What's it look and sound like when they are experiencing anxiety, and how are they tracking that? Are they having that data brought to the prescribing practitioner? Demonstrated skills and assessment of challenging behavior, writing reports on those things. Crisis prevention through the use of proactive, positive environmental supports. This I can't say enough about. It is counter to how we all think when someone's experiencing a crisis, yelling and screaming and carrying on, to think what is lacking in their quality of life in that moment. Because our tendency is to focus on the yelling and screaming and the carrying on, which tends to reinforce it. And then we end up ignoring kind of what might be the root cause of it by looking at improving the person's quality of life. And that involves using proactive strategies and doing it on a day-to-day basis. For some people, it means doing it hour to hour. If a provider has no structured, proactive programming that they offer, and instead they just rely on the good nature of the staff, hopefully they got great personalities and they match well with the person, and then all of the focus of their support is in crisis management, that's a problem. That might be something to have a conversation about. And then the development and implementation of transition plan for people who are specifically in out-of-home crisis respite daily. You could ask for a blank transition plan. What's your template look like? What's your process? What's your timeline? How do you ensure continuity of care? How do you know the next provider gets it, like knows what to do? Those are all good questions to ask. On the next slide, the last bit is on qualifications. The first three bullets, I'm not going to really touch on. It's the fourth bullet that I think everybody should be the most aware of. So for a crisis respite provider to be licensed in this 245D service, they need 4 years of full-time supervised experience working with people who exhibit that challenging behavior, as well as co-occurring mental disorders and neurocognitive disorders. That means a direct support professional who has that 4 years of full-time supervised experience can be the owner, operator, program developer for a crisis respite program. And that could be concerning as to whether or not they know how to do a functional behavior assessment, write a positive support transition plan, develop data tracking systems. I've worked as a direct support professional. I didn't have to do that. I had to write progress notes, pass medications, and implement the plans, but I was never asked to do any sort of assessment. So that bit of experience and qualifications is one to be on the lookout for and have a conversation about. Next slide. I already mentioned the DHS licensing lookup. This is a screenshot of one of the crisis respite providers' license page. The blue linked lines there are corrective actions or maltreatment reports. So this is a real provider who has a lot going on. You can go in and read all of those reports and see. Now, a lot of the times, some of these things are, they didn't have the staff training record up to date. Small things related to paperwork. But sometimes there's a report about one of the DSPs driving the person around intoxicated all day. That might be a report you want to look into a little further. So just wanted to make you aware that this is another way to vet a provider, to check in and see if they have any of these things on their license. Next slide. So recognizing the need for crisis respite, this has kind of been touched on. I think Liz covered some things earlier in the presentation, but things to look out for, maybe ask parents, if you're working with kids, if you're supporting adults, check in with whoever their primary caregivers are. Has there been any calls to 911? Because sometimes they don't tell the waiver case manager about this until it's kind of too late. Is there going to be a service suspension or a termination? Is there some things going on and the provider, the licensed 245D providers, kind of talking about those things? They haven't done it yet, but they might start talking about it. Being hospitalized one or more times, if there is the utilization of emergency use of manual restraint, and then again, the family showing signs of stress. On the last two slides, I'm going to go over pros and cons for the different ways in which this service is delivered. The 15-minute, nobody has to move. It's the least disruption to the person's daily life. Anybody who has the 245D crisis respite license can provide that as a mobile 15-minute service. And it can also be provided at work, places of the community, and there's that piece about no time limit. In-home daily, again, person doesn't have to move. There's the 24/7 staffing that is provided, and there's no time limit. Out-of-home daily, the biggest pro on this end of it is that the residential piece of it, there's some place for the person to live while they're receiving the service. That's the biggest pro on out-of-home crisis respite daily. For cons on the next slide, there's not really any with the 15-minute. In-home daily, 24/7 staffing is hard for providers to maintain, to find enough staff to do. And it's also hard for families to have staff coming in and out of their home 24/7. Out-of-home daily carries with it the most cons. So the person's guaranteed to have to move twice, once into that setting and once out of it. It's going to cause the most disruption to their life as a result of having to move. And then only can be provided in licensed settings, which then creates a time limit and an age limit. For those providers, 24/7 staffing is hard to find and maintain. Another drawback is often in these environments, people are grouped with others who are also experiencing a crisis. So that can be challenging for people to live with others in crisis. Sometimes people can get stuck in these settings because of lack of capacity in long-term settings. And then it does require that formal transition process. Okay. Next slide. Ashley, are you up? You're muted.
My apologies. Yes, I am up next. We have had a couple other questions come in, but I
okay.
think we'll circle back at the end because we actually have time. So we're running really good on time today.
Okay.
Okay, so putting it all together. One of our goals in providing you with this information was to help you know a little bit about the variety of services and supports that are available all across the child welfare continuum, but they may be outside of the scope of your specific case management responsibilities. So some of these services are reactive, some are proactive. And when you're looking at your caseload, we want to strongly encourage you to think about how you can be proactive and engage services before there's a crisis. So what does working proactively mean? It means changing the oil before it turns to sludge. It means not waiting until you have to act, going to the dentist to prevent cavities, watering your plants before they dry out. And it's often the case that acting before you have to will be more efficient, and it's going to cause both the least amount of damage to the client that you're serving, but also the least amount of stress for yourself. Next slide, please. So think back to that recurring visual that we had showed you about what the child's needs are. Are they urgent? Are they emerging? Are they just beginning? And when you're looking at their needs and considering where they might fall in those categories, also consider some other personal factors, like we had mentioned before. What is their history of trauma? How might that play in? Would they benefit from therapy? Would they benefit from some behavioral supports? What sorts of natural supports do they have? How can you engage family, relatives, kin, coaches, neighbors? What cultural connections do they have? What is the stability of their current living situation? Look at all of these things when you're considering engaging services, and how can you leverage those services and supports through children's mental health or waiver services or some of our prevention services and child welfare to really support the child and their family to ensure that they're able to get the support that they need. Okay, next slide. Our next slide is resources. So I think before we jump into resources, there was a question in here for Di. And Di, I am just going to call on you and see if you wanted to answer that question.
Sure, I was just typing it in chat. So yeah, I think, the best way to consider it is DHS considers the completion of a crisis plan, which is what the question was, where is it in statute? We consider it best practice when doing CMHTCM. And one of the questions a person might want to think too is why we would not want to do them. Is that helpful for the family? Is it a way to, and the answer is probably no, it's not helpful to not do a crisis plan. It's also a great way to look at really kind of putting into paper ways to have a tangible way to refer somebody for services or for emergency, but the family to own it and say, I recognize this is my way to avoid a crisis. I've written it down. I've talked about it with the case manager. So yeah, when we look at stuff like that, so that's where we talk about best practices. Not everything will be in statute when we look at things like that. So I hope that's helpful.
You die. Okay, I think we might have maybe one more question there as well. So we might be able to get to that question. I am not sure, but let me just go through the resource section while we are taking a look at that. So these are the email addresses for the various areas that presented today. For the first one, that will get you to Liz and I, that is our foster care policy area. The second email address on there is for permanency, which would be where Alicia is from. For behavioral health, we have Di's direct email address because she is the children's mental health guru. And then for our disability services division for Amber, best way to reach her is going to be through the positive supports email, and anything positive supports can go there. And then lastly, we have general questions on waiver policy, eligibility, anything else that might not neatly fit into a disability related category. You can use the DSD contact form, and that is DHS EDOC number 8168. And as we said at the beginning of this presentation, these slides will be available. We are getting them through the accessibility process. So all of those links will be clickable once we get it through that process and made available to you. Next slide, please, and I will pass it to Amber.
Okay, a couple of positive support resources to make folks aware of. So there's the Positive Supports Minnesota, mnpsp.org. That was work between the Disability Services Division and the Institute on Community Integration, the University of Minnesota. You could spend a week digging around on here. There's so many resources. There's templates of examples of things, and that could be for a provider, it could be for a parent. There's things relevant to case managers. I encourage you to check it out. There's really some great stuff on there. Guidelines for positive supports in DHS license settings. This is a manual that's designed for 245D licensed providers. However, it might be something you might want to be aware of because it does outline some of the things that are allowed and prohibited in supporting a person with challenging behavior. And the Disability Services Division training handout archive. There's a link there so you can go back, peruse through all the past trainings, check out the PowerPoints there. Positive supports page, we have one dedicated just to things positive supports. The last bullet link, that list of person-centered planning facilitators, is found on that DHS positive supports page. And what that is it's an Excel sheet that has a list of formally trained person-centered plan facilitators around the whole state, their name and contact information. So if you're looking for that service, you can bill it under family training and counseling. That is an excellent way to find providers. And then our e-list or DSD e-list. So we send out information pretty regularly. If you've missed something, you can check it out in the archive, go back and reread things. Do I have any other resource slides? Is there another one?
No, that was it, Amber. Thank you. Okay, so we did get one more question, but we are going to need to coordinate our response with that because it's a little bit more tricky than we had initially thought. So we will be posting a consolidation of all of the Q&A question and answers that we received from this webinar and from the one last week. And that will be posted when we post the recording of this webinar as well as the slides. So y'all will get an email about that. And so you'll be able to look for answers to those questions there. So this last slide here is just general program resources that we thought might be helpful for you. So different services that are offered by the Department of Human Services and also by community-based providers. So there's community support services, which is a program through our direct care and treatment. Early intensive developmental and behavioral intervention is a very fantastic proactive service that can be used for children, not just who have autism, but who have also related conditions. So that's another one to check out. The Minnesota Intensive Therapeutic Foster Homes. That program is run through the Department of Human Services, Direct Care and Treatment also, and we have program information listed there as well as the state-operated services. Intensive treatment in foster care is a service that can be provided in a foster home. It's therapy, it's family therapy, behavior training. It's a very robust service that is available and can be utilized. Sometimes children with complex needs need a much higher level of treatment, and that can potentially be accomplished at a psychiatric residential treatment facility. The way I understand how that type of a program is it is just under inpatient level of care for treatment needs. And then, as I referenced earlier, when a question was directed about a placement authority with crisis respite. This link, which you will have available, is our bulletin on when that service is considered a foster care placement and when placement authority is required. Okay. And I think that that is it. Did we have any? It looks like I don't think we have any other questions right at the moment. So thank you all so much for joining us for this presentation. You will be getting an email with the recording of it and with the slides, and we appreciate you joining us today. I'll pass it back to Liz to say goodbye.
Thank you, Ashley. I think I'll just give another minute or two to see if we have any other questions that come in. And then if not, we will end the recording and the webinar. And as Ashley mentioned, the webinar recording, the slides, and a summary of the Q&As that were asked in this webinar and last week's webinar will all be posted to the DSD archives, and an email will go out to attendees as well. I'm going to give it about 30 more seconds to see if any other questions come in.
I have one answer. I was trying to figure out what this question meant from Melissa. If
Yeah,
the
Di, will
question-
you read the question before you answer it?
Sure.
Thank you.
It says, can you clarify who does the out-of-home placement plan? Does TCM have to make one, or can they just coordinate with one provided by child welfare? So I'm assuming that's CMH TCM. I'm assuming. So if it's CMH TCM, that's two different services. And so each service has a different out-of-home placement plan, right? Because you're going to have different goals and different objectives. So if that's what that question means, that's what the answer is. And we're going to send out we'll have that in Q&A too. Otherwise, Melissa, if it isn't what you asked, please indicate that here. Okie dokie. Thank you.
All right, I am not seeing any other questions. I do have the slide up with the email addresses for the divisions and presenters today. So if you think of a question afterwards, please utilize these emails. Thank you so much again for attending, and we appreciate everyone's time.